Welcome everybody to this session of the Symposium on extra costs of disability. I'm Daniel Mont, the co-president of the Center for Inclusive Policy, and I'm very happy to be here to hear these two excellent papers. As many of you probably know, there's been an increased recognition of the importance of the extra costs of disability, but the challenge is to try to measure them accurately and figure out how to incorporate them into the design of social policy. And today we're going to hear from two papers that help take us significantly down the road to trying to figure those things out. One from the United States and one from Bangladesh. So the first, and as Kyle just said, if you have any questions or comments, please enter them in the Q&A box and we'll deal with them after the presentation. The first paper is from Stephen McGarity from the University of Tennessee. So Stephen, why don't you take it away?
Thank you, Dan. I appreciate that. I'll just share my screen here. And if you all could let me know if you see that. Dan, I see you. Can you give me a, okay, great, excellent. And just as a precaution and out of a courtesy, I'm actually going to stop sharing my video because of my internet connection. I don't want it to freeze up in the middle of the presentation. I will turn it back on for the question and answer of the discussion afterwards. So thank you all for coming out. It's early in the morning for some of you, maybe in the evening or afternoon for others, but I appreciate you coming out. My name is Stephen McGarity. I'm an assistant professor at the University of Tennessee, Knoxville. And I'm presenting a paper today on the extra cost associated with living with a disability in the United States. This paper was authored by myself and three co-authors, three colleagues of mine, Dr. Zachary Morris with Stony Brook University, Nanette Goodman with the National Disability Institute, and Dr. Asghar Zaidi from the Government College University in Lahore. And just before we start, I also wanted to note that the research that kind of culminated with this paper was the really result of a grant that was funded by the FINRA Investor Education Foundation. So just for full transparency, I wanted to mention that. So first, some background from the literature that really serves as the purpose for our study. We know that people with disabilities experience financial inequalities at much greater rates than people without disabilities. For example, we know that people with disabilities are twice as likely to find it very difficult to cover living expenses. We know that people with disabilities are twice as likely to have past due medical bills. They're twice as likely to use alternative financial services like payday loans, pawn shops, title loans, and also they're twice as likely to live in poverty. And some of those inequalities can be explained, at least in part, by disability-related expenses like durable medical equipment, out-of-pocket health expenses, modified transportation, et cetera. And we'll get into a few more of these in just a few minutes. The main theoretical framework that undergirds our study comes from the economist Amartya Sen, who discussed two distinct kinds of financial disadvantage that people with disabilities face. The first that he discussed is the earnings disadvantage, which results in financial hardships from not having enough access to things like suitable education or opportunity to acquire human capital. And then the second financial disadvantage that he talks about, which is the one that we kind of focus our research on, is called a conversion disadvantage. And so Sen discusses how because of disability-related costs, it's harder for people with disabilities to convert income into the same standard of living as people without disabilities. And so the classic kind of example that we like to give is a person with a disability who has a $40,000 annual income isn't able to really afford the same standard of living as a person with a $40,000 income who does not have a disability because of those extra disability related expenses. So what are some of these extra costs of disability? They can really be broken down into two overarching categories, indirect costs and direct costs. So some of the indirect costs might be foregone earnings that people with disabilities have because they might face barriers to work. It could also be foregone earnings that family members might forego because they've had to reduce the amount they work in order to provide care work for a person in the family with a disability. And then some direct out-of-pocket costs are things that might intuitively come to mind when you think about direct cost or extra cost. Things like personal assistive devices, out-of-pocket healthcare costs for things that might not be covered by insurance, extra costs for housing that might be accessible or geographically convenient to services, more expensive cars that might accommodate modifications. So we see this a lot with people who use wheelchairs, having to buy a van that can then be modified, maintaining service animals, the extra costs for certain types of foods for special diets, and the list literally goes on and on. And there's actually a pretty thorough conversation that I would point you to that covers really both the indirect and the direct cost of disability, and it's on Twitter. There's a hashtag, actually two hashtags called disability tax and crib tax. And these hashtags were started by the disability community to really start discussing what some of these extra costs of disability are. And so I would encourage you to not only check it out, but join in on the conversation as well. All right, so we know that people with disabilities have to spend extra money on disability related costs, which in turn impacts their overall financial well-being. We also know what some of those costs are, though that's still a fairly under-researched area, especially in the US. And there's several approaches that researchers use to measure the extra cost of disability. The first is called the goods and services approach. And this involves an interviewer asking a person with a disability about their disability related expenses. So it's a direct approach, a qualitative approach, and it really goes directly to, you know, how much do you spend, how much extra do you spend for these disability related items? The second approach really builds off of that approach, and it's called the goods and services required method or approach, which is it essentially asks what expenses or what do you need to expend in order to fully participate in society, right? And these two approaches really yield a detailed picture of extra costs, but they're expensive and they can be labor intensive. And so that's why we see oftentimes in the extra cost literature, the third approach, which is the one that we base our paper around today, and that's called the standard of living approach. So the standard of living approach is a statistical approach. It estimates the additional income that's required to really close the standard of living gap between households with and without disabilities. It uses national household data to compare the standards of living of similar households. And just, I guess, one example would be if two households lived in the same geographic area, if they had similar household size, a similar racial and ethnic composition, the household that contained a member with a disability would have extra costs, which this method can then get at showing. So for our study, we used 4 different household surveys in the US. We used 2 waves of the National Financial Capability Study from 2015 and 2018. We used a 2018 wave of the US Financial Health Pulse Survey, the 2016 wave of the Financial Wellbeing Survey, and the 2018 survey of household and economic decision-making, or colloquially just known as the SHED. We also used the US Current Population Study to produce rates of poverty that are adjusted for our extra cost estimate, and we'll kind of show that slide towards the end. Because of data limitations, and this is the case oftentimes with the standard of living approach, and it's really just a general limitation of secondary data analysis in general, but we were really limited in how we were able to define disability, limited to what was available in the data. And so because of that, our conceptualization of disability was really as a work limiting disability, with the exception of the 2015 National Financial Capability Study, which asked about the 6 impairment types. So we were able to kind of drill down a little bit and look at impairment types, but that wasn't widely available across all the data sets we used. In terms of the standard of living variable, we were able to kind of standardize these across all the data sets, and we used measures of financial security. So survey takers were asked to respond to certain statements. For example, because of my financial situation, I feel I will never have the things I want in life. I'm just getting by financially. I'm concerned that the money I have will not last. So just diving into some of the results. 2 of the main takeaways from our study are really right here on this first slide, or at least 2 of the main takeaways that we believe are most important. The first is the finding that people with disabilities in the US require an estimated 28% more income to achieve the same standard of living as a similar household without a person with a disability. And if you look at the figure that we provide here, you can see that that 28% estimate is an average across all 4 of the data sets that we used. And that the individual estimates range from as low as 24% in the SHED to as high as 32% in the NFCS, all of which were kind of in a really close range there. And then one of the other main pieces of information that we would like you to leave with is what that 28% might translate to in the real world for families with disabilities. And so at the national median income in the US, an extra 28% means that households with a disability would need an additional $17,690 per year to maintain the same standard of living as a comparable household without a disability. And so if you drill down to some of the subgroup comparisons, we can see that single individuals with disabilities require 36% more income than single individuals with no disabilities, while married people with disabilities require 25% more income. And so the data and really this approach doesn't allow us to answer why that 11% difference exists between single and married people with disabilities. But we kind of hypothesize that the difference can be accounted for somewhat by the sharing of household expenses and the informal care from partners. But again, this is where an additional approach like the goods and services or goods and services required would really shine. Next, we looked at the extra cost and gender. We didn't actually observe any consistent statistical differences in the extra cost for men or women with disabilities when compared to men and women without disabilities. But we wanted to include this in the presentation just in case some of you had questions about this particular subgroup. Also, the same happened with race. We weren't able to actually discern any consistent statistical differences across the surveys with race either. Next, we examined the extra cost by disability type. And we did this by using data from the 2015 National Financial Capability Study, which again had the 6 impairment types. And what we found was that adults with 1 or more impairments required an estimated additional 35% income to meet their living standards. And this is important because it captures people with a disability who might also be working, whereas the other data sets we looked at only captured individuals with a work disability. A couple of other interesting results were that adults with cognitive impairments were found to have the highest extra cost at 29%, while individuals with hearing impairments had the lowest extra cost at 6%. So one of the things we started wondering about towards the end of our study was how the poverty rates might change for people with disabilities if these extra costs were taken into account. And so we looked at the federal poverty levels and we adjusted them based on our finding that people with disabilities require 28% more income. And what we found was that the rate of poverty among people with disabilities would actually increase from 24% to 35% if these extra costs were included. And you know, this is consistent with the international literature on standard of living. And it's consistently shown across the world that if these poverty levels are adjusted for extra costs, inevitably what ends up happening is the more people with disabilities are counted in those poverty measures. In the US, that would result in an additional 2.2 million people being included in the poverty estimates and potentially becoming eligible for federal benefits programs. And so you see in the graph here that we provide, we have poverty levels at the 100%, the 133%, and the 400% levels. And these thresholds all correspond to various eligibility requirements for several of the benefits programs in the US. You can see that the dark bars represent the current poverty levels for people with disabilities, and then the light bars would represent what the poverty levels would be if adjusted for these extra costs. Just give you a second to take a look at that. All right. So like all research, there were some limitations to our study that we'd be remiss to not acknowledge. The first limitation is that the standard of living approach that we used doesn't uncover the types of expenses that are driving these extra costs. It does tell us that there are extra costs, but it can't really tell us what those extra costs are. The second limitation is that these estimates provide an average across all people with work-related disabilities, but they can't really be used to identify extra costs for each individual. So for example, the extra costs might differ by severity of disability, but we just can't really speak to that with this approach. Again, other approaches would really shine in this area. The third limitation is that this approach doesn't really help explain how disability impacts the income of the individual or the family member. For example, if family members have to reduce their work hours to provide care, the lost income isn't really captured with the standard of living approach. And then the last limitation isn't necessarily about the standard of living approach, but more about the data we used. We used cross-sectional data, and because of that, the data can't really identify differences between the extra cost of people with long-term versus short-term disabilities, or how those extra costs really vary over the course of a lifetime, or really any kind of longitudinal trends. And so in terms of future research, we think what needs to be done is, or at least for us, is to seek to identify disability-specific consumption items that can further explain the problem and help identify opportunities for intervention and policy responses. Conduct mixed methods research to understand the hard to measure cost and the lived experiences of people with disabilities. So perhaps combining some of those approaches to measuring the standard of living, and then further develop and evaluate disability specific financial planning tools for people with disabilities and financial professionals. I believe Dr. Mitra sent out a copy of our working paper. If you would like to access it, if you didn't have access to it already, you can actually go to the website for the National Disability Institute, and it's under their reports and extra costs of living with a disability. You can download it there. And I believe we can have a discussion now.
Great, thanks a lot. That was a great presentation. And I have to say, it's very rare for me to see somebody get the same result across 4 or 5 different data sets. So you must have been quite happy and relieved when that happened. If people have questions, again, please enter them in the question and answer box. So that there's a first question from Michael Palmer. He asks, thanks for your great presentation. How do your estimates compare to other OECD countries? 28% seems a bit low compared to estimates from Europe. Any ideas on why this may be so? And it would be interesting to see cost estimates by age of the person with a disability.
Yeah, so thank you, Michael, for your question. Yeah, so that's certainly a question we grappled with as we were going over the results. And so, you know, you're right, 28% is a bit lower than some of the European countries, particularly like Germany, I believe. But I think one of the things we try to be careful to not do is do this kind of cross-national comparison, because a lot of the data wasn't necessarily harmonized. And so we weren't necessarily working with, you know, the same types of data in each country. And so I believe that we never came to a firm, I guess, approximation or hypothesis for why those differences might be, and why the US might be a bit lower than in other countries. But it's certainly something that we feel maybe could provide a nice future study, some kind of international comparison. And in terms of person, looking at the age, we did actually break that down, and we didn't include it in the slide. And actually, I'm not quite sure why we didn't include that piece. But essentially, disability costs, or the extra cost of disability, certainly do increase with age. And so I don't know, again, I don't know how we left that out of the slide, I'm sorry. But yeah, that was definitely a relationship that we noticed in our data.
The next question is, how is US policy does US policy account for these extra costs, and does it do it in a good way?
Yeah, so there are a few policy mechanisms in the US that account for these extra costs. I think we would argue maybe not enough. It's handled, for example, a lot of times via the tax code. And so people with disabilities can write off certain healthcare expenses that are outside of their, or above a certain percentage of their income each year. The problem with that method of kind of accounting for extra costs is many people don't take advantage of those tax subsidies. We know that it can be sort of regressive. So those kind of upper middle class and upper class families tend to take advantage of tax write-offs much more than lower income individuals. There's also things, more recently, there's the ABLE accounts in the US, which are tax advantage savings accounts that really recognize the extra costs of disability. And so a person with a disability can open an ABLE account and they can save money in this tax advantaged account. So they're not taxed on the income from the investment account. And then they can withdraw those funds to pay for disability related expenses. There's a lot of issues with the ABLE accounts currently. They're actually limited by age. So you have to have a disability that was onset by the age of 26. So if your disability occurred after the age of 26, you wouldn't be eligible to open an ABLE account. And they're also limited in how much a person with a disability can save in those ABLE accounts. I think currently the federal limit is around $100,000, which is a marked difference from, if you're a person with a disability who receives government assistance in the US, you've currently been kind of limited to a $2,000 asset limit. So you couldn't save more than $2,000. So this does increase that significantly, but it certainly has some limitations. And there's lots of research being done now about the ABLE accounts and how effective they are, essentially. It's a good question, though. Thank you.
The next question from Mark Asper is, how would intersectional groups be accounted for in terms of extra costs? For example, how would a single white woman versus a single Black man be reflected?
Yeah, so I think that's a really interesting question. And I think we were cautious, we didn't necessarily want to start going down, drilling down too deep into the subgroup analyses, because at the end of the day, these are really estimates. And so it can tell us that there are extra costs, that there's a kind of a directionality. But I think in order to really start drilling down into looking at some of those intersectional comparisons or associations, I think we would need to turn to a much more in-depth approach, like the goods and services or goods and services received.
Okay, so we have 5 more minutes before it's Morgan's turn, and we have 2 more questions. So the first is, very interesting presentation. This is from Jacqueline Yap. Very interesting presentation. Are you able to look at consumer debts incurred as well as in the data set?
So as far as I know, and there's people who are much better versed and well versed in this standard of living approach than I am. I don't believe the standard of living approach accounts for debt, and though that is something that, again, we discussed on our research team. How could you really get at looking at debt and how that debt impacts standard of living? I think that that's certainly a shortcoming, especially when you look at things like healthcare debt. As I mentioned earlier in the presentation, people with disabilities are twice as likely to have debt from medical care. And so that certainly would impact the standard of living that you are able to achieve. And so I think that could be a great future step for sure. And I don't know, I also want to let everyone know if those who are more well-versed in standard of living approaches, if you would love to chime in, that would be okay with me too.
Okay, last question. This one's mine. So most of the standard of living approach research that I've seen has used asset indices to measure sort of wealth. And you use a different measure of standard of living, which is people's sort of subjective notion of how well they're living. What implications do you think it has to compare that type of measure with an asset index? Or, what do you think the implications of that are, if any? Yeah,
so I think it works well for the US. I think that, so we followed really the 2 kind of golden rules of standard of living when you're choosing a standard of living variable that were kind of created by Asghar Zaidi. And that was that it should be highly elastic to income to kind of help ensure that it's sensitive to changes in available resources. And then also that it should consist of items that are desired by all people, so it's kind of independent of ability. And we felt that these indices that we chose really did hit those 2 marks. But I think to the point you're getting at, there aren't a lot of data sets in the US that really focus on expenditures in the way that we wanted to capture them, and also combined with those disability variables. And so we really were limited in the data that we were using in the US. And so, for example, in other countries, I know that there's a list of consumption items that people consume. And we do have a similar data set in the US, but the disability variable in that data set is much more imperfect than the ones we were using. So it would have been harder to get at with the data that we had available. In terms of implications of that, that's a good question. I would maybe throw it back to you or to the other people. Maybe, I don't know.
Oh, I don't know. I mean, I don't know how many more research ideas you need, but if you could find a place where we could use both in the same data set, it would be really interesting to see how robust it was across. You know,
and to maybe compare, the differences.
Yeah. I couldn't say. I didn't have the answer. I was curious on your opinion.
Yeah, no, that's a great question.
So we've gotten to, thank you very much. I think it was a great presentation and a really nice discussion. And now we have to move on to Morgon Banks from the London School of Hygiene and Tropical Medicine, who is looking at the same issues, but has a different, using a different measure of extra costs in a very different setting. So Morgan, I turn it over to you. I can't hear you, Morgan. Are you?
Yes. How about now? Is that better? Perfect. Well, thank you very much for the introduction, and thank you, Stephen. That was a really interesting presentation. So I'm going to take a bit of a different approach for the talk that I'll be giving now. So I'm going to be looking at the direct and indirect costs of disability amongst working age versus the disability in Dhaka, Bangladesh, and Nairobi, Kenya. So this was a collaborative project done with researchers at the London School of Hygiene and Tropical Medicine, Shaffa Hameed and Tom Shakespeare, Ola Abu Alghaib, as well as Emily Nyariki and Joyce Olenja at the University of Nairobi. So this study was part of the Innovation to Inclusion Consortium. So this is a consortium that is working in Bangladesh and Kenya on improving access to waged employment for people with disabilities. So they are trialing an intervention at the moment. And so this was a piece of qualitative research that was feeding into that larger project. So some of the specific objectives of this research was to look at the sources of direct and indirect costs, as well as factors affecting the magnitude of those costs and ability to meet them. We also looked at some of the impacts of costs amongst people with disabilities and their households, as well as the strategies that were used for meeting costs. So I think Stephen has given a really good overview of the definition of indirect and direct costs already, so I won't spend too much time on this. Just to say, by indirect costs, referring to reduced opportunities for earning, earning challenges under the capability approach, whereas direct costs are additional spending on goods and services required by people with disabilities for health and participation. So that conversion challenges under the capability approach. So for this study, we took a qualitative approach. So I think it's a nice complement to the quantitative approach taken by Stephen. So we did 40 in-depth interviews with people with disabilities in Dhaka and Nairobi. So this was a purpose of selection to maximize heterogeneity by age, gender, and impairment type. And the focus was on working age adults. So as I'm presenting the findings, I think just a note on generalizability that it's primarily urban population, working age adults, and selection was primarily through DPOs and NGOs with some snowball sampling. So there is some limitation there in terms of these are probably people that are a bit better connected and probably have better access to goods and services. And we analyzed the qualitative interview transcripts using thematic analysis. So if I first start with the types of costs that people incurred. So if we start with the indirect costs, so not surprisingly, we saw that people experienced limited employment opportunities and lower salaries. So I have a quote here from a man with a physical impairment in Bangladesh who is explaining, sometimes people are not agreeing to do some works because this work demands low payment. They don't do this work, this type of work is given to me. I do this work because a little earning is better than nothing. And the impact of disability on employment opportunities and salaries was clearest for people who had an onset of disability during their working years. So in asking people to compare both their opportunities and their earnings pre and post onset, you could see quite a significant change in the opportunities that they were afforded. And this included people whose disability did not impact the type of job that they were doing. We also saw indirect costs in terms of additional time. So travel was a big one. So for example, even people that could use public transportation, some of them would have to wait longer periods for a slightly more accessible bus to come through that would maybe stop for them to board, or that would have a low enough entryway that they could climb on. It also took much longer to find jobs, so that's more time out of the job market. And then also when people who had an onset of disability during their school years, it was quite common that they had gaps in their schooling, they had later starts, and this either affected their total amount of schooling or when they entered the job market. And then there was also the indirect cost in terms of household members' time in providing assistance and helping people with disabilities navigate inaccessible environments and structures. Turning to direct costs, so medical was certainly a very large source of costs, and this is not surprising. This is found in many different settings. Typically, medical costs were highest at the outset of disability as people were looking for diagnoses or dealing with acute care. But for almost everyone, there were ongoing medical costs. So maybe this was replacing or repairing an assisted devices, or for some people, certain health conditions required ongoing healthcare. So this is particularly true for people with psychosocial disabilities. So here we have a quote from a man in Kenya who is explaining that there's older generations of medications that cost between $5 to $10 per month. But the new generation of medications, which are more effective and have fewer side effects, cost between $20 to $50 per month. And you might have a person that needs multiple kinds of medications in their regimen. And so this really is not cheap for many people, particularly people who are also living in poverty. There were also direct costs in terms of accommodations at work and school. Many of these were unmet costs, as well as for transportation. So needing more transportation for people with mobility limitations who perhaps couldn't walk a distance a person without a disability could, but also even for using the same type of transportation. So it was quite common, for example, in Kenya, people reported paying drivers tips for them to stop longer for them to board the bus. A few people also paid for personal assistance, but this was mostly an indirect cost borne by other household members. I also wanted to emphasize that there were costs associated with working. So I think there's often a thought that when someone is working, this is purely positive. However, working was not a zero cost endeavor. So while having a job brought in additional income, which reduces indirect costs, it could also bring other types of costs. So for example, there were disability related costs. The consumption of transportation went up. Sometimes people needed to pay for accommodations themselves out of pocket. And also, while not a disability related cost for people living in poverty and looking at self-employment, there was also oftentimes quite high upfront costs to starting a business, and this could be risky as well. So that was a challenge for some people to meet. And what's also important is that there were also costs for looking for a job. So at least with having a job, that brought in an income, and that could change the calculus a little bit. But for people who are searching, when there's no guarantee of having a job at the end, this could be very costly. So here we have a woman who is explaining the hearing impairment through a sign language interpreter that she goes to look for a job, but every time she's told they have many applicants to come back. So it's quite high cost. She's traveling to these application points. She's spending her time, other household members' time in going for these jobs. So I think this is important to consider when looking at improving access to work for people with disabilities, that getting that job can carry costs and holding the job. It was also interesting looking at some of the factors that affected both the magnitude of costs and households' ability to meet them. So I think we traditionally focus quite heavily on the lack of income, and this was absolutely a problem in both settings amongst all participant groups. Lack of income was a major challenge in meeting direct costs. But there were also a number of other factors. So one of them was, for example, the lack of decision-making power within the household. So these costs are often decided upon from within the household budget, and so there are different discussions that need to go on in terms of what the money gets allocated to. And people with disabilities may not always have that decision-making power within the household in order for their expenses to be prioritized. And we found this was particularly true for women with disabilities, so the dual impact of gender and disability in the decision-making process. As an example, we had 3 women in Bangladesh who were given startup capital to start their own businesses. So that would have reduced their indirect costs. However, all 3 of them gave that startup capital to a male family member without a disability for them to run the business. And the benefits of that business were not translated into a better well-being for them. There was also the impact of limited information about the types of goods and services that were needed. So this came out quite strongly in both settings. So it wasn't just about not having income, but it was about knowing what was needed, where to access it. And this was closely linked to the poor availability of these needed goods and services. So we have here, for example, a man with a hearing impairment in Kenya who was explaining by sign language that after I became deaf, I didn't go to school. I stayed at home for 2 years, and my mother and father had no idea where to take me for school. But a friend of my mother explained to her that there's a school for the deaf. We went to the school, and she was very surprised that there are very many deaf children there, and they're using sign language. So here we can see a few things going on. We can see that there's clearly an indirect cost in that this man was out of school for 2 years, which ultimately impacts either his ultimate school attainment or when he enters the labor force. And here we're seeing that maybe income was an issue as well, but the bigger issue is not knowing that there are these types of goods and services. So his parents had no idea that there was education available for children who are deaf. And this may be linked to poor availability of inclusive education. So this school that he went to was not in his community. If there had been more local inclusive education options, he might not have faced these indirect costs. And linked to this, there were quite a number of costs that needed public rather than private spending. So there would never be the expectation for an individual to be able to fund inclusive education or accessible infrastructure on a large scale. So I think highlighting, we'll talk a little bit later about some of the policy implications. I'll talk briefly about the impact of costs. So one thing that's important to note is that unmet direct costs often led to higher direct and indirect costs in the future. So you might have, for example, someone who is unable to afford sort of a basic medical procedure early on in disability onset, and that led to worsening severity and worsening participation restrictions. Financial strain was also very common. So managing direct costs when people are living in poverty, so that indirect costs, the combination of those two was quite difficult for households to manage. Inability to meet direct costs often led to reduced health functioning and well-being. So for example, not being able to afford an assisted device or rehabilitation. And the ultimate impact was on decreased participation, so impacts on work, on education, and social life. And households used a variety of strategies to meet these costs. So almost everyone paid out of pocket for at least some portion of expenses through either the current income or the savings. Loans were also quite common, and this could really reinforce a cycle of poverty. People would take out loans at quite high interest rates to meet either everyday expenses associated with poverty or to pay for a direct cost. There were also, though, examples of either employers or schools or NGOs, DPOs, and other organizations that could provide for some of these costs. So, for example, example, trainings to improve employment opportunities or provision of an assistive device is sort of a one-off were reported. And then the last strategy, which I'll focus the remainder of my talk on, is the role of social protection. So both settings had different social protection programs that could be used to offset either direct or indirect costs. So for example, there were programs to improve earning opportunities or the indirect costs. So both countries had quotas to increase formal employment amongst people with disabilities. I will note that in Bangladesh, at the time of data collection, the quota had been suspended. And there was also some subsidized training and job matching programs run through the government. I should say that I'm focused on social protection provided by government rather than more sort of NGO, DPO programs. There were also programs that were focused on direct costs. So for example, in Kenya, there was a free provision of assisted devices. Both settings had cash transfers. And in Kenya, they had income tax exemptions. So these were for people in the formal sector earning below a certain threshold. They were exempt from the 30% national income tax. As well as in Kenya, there was a public health insurance option. So social protection was used as a strategy for managing costs. And this was particularly in Kenya, much more so than in Bangladesh, which I think is understandable given the wider availability of programs in Kenya. Now I'm going to talk a little bit about some of the limitations of these different programs in terms of meeting extra costs, direct and indirect, for people with disabilities. The one thing that I should say for all of these programs that are disability targeted, social protection also came with its own costs. So people had to register to be part of the program, which involved a assessment of disability, which almost always involved medical documentation of an impairment, as well as traveling to application points. So getting these benefits came with upfront costs. But if I look at specific programs, if I start first with the cash transfer, so in both settings, the amount was really too small in order to adequately meet the range of costs that people with disabilities faced. So in Bangladesh, this was equivalent to $8 per month, while in Kenya, this was $20 per month. So this was really inadequate, both on its own, but also due to the eligibility. So in both settings, these were means-tested programs, and they were focused on people that were in quite extreme poverty. So in Kenya, for example, no one in the household could earn an income or receive a pension. So we're talking about quite severe poverty. Similarly, in Kenya, they were focused on people with very severe disabilities, so needing full-time caregiving support, which, given the small amount, was really inadequate to cover all the costs needed. Turning to health insurance, so this was for Kenya only. There was the public program, which is the National Hospital Insurance Fund. This is not disability targeted, but it's available to all Kenyan nationals, and people do have to register and pay some fees to enroll. The main issue with this was that there was very limited coverage of disability-related healthcare. And I think we're starting to see this as a common theme across several different countries that are focused on universal health coverage and the role of health insurance. So it's good for general health care, but not so much the types of services needed by people with disabilities. The limited coverage of rehabilitation, mostly older gender medications for psychosocial disabilities. And even when services were covered, there was an issue around availability and quality of those services. So for example, some respondents pointed out that there were very few specialists that actually worked in the public sector, preferring to work instead in the higher paying public practice or private practice. So for example, psychiatrists, most would have to go into the private sector. And this led some people to purchasing private health insurance, which was quite a bit more expensive and also was insufficient. So there was still caps on spending for certain services. This was particularly noted for psychiatry services. So that cap not being adequate to meet the full range of healthcare needs. There were also other programs. So assisted devices were provided outside of health insurance in Kenya. However, there was quite complex application procedures and the wait times could be quite long. So in Kenya, a woman with a visual impairment was explaining that a few times she's gone to the National Council to ask for a white cane, but you were told you have to fill out an application form and wait for one. Because I cannot move around without one, I now resort to buying one. So you can see here that there is the challenge between the direct cost of purchasing out of pocket that assistive device, but then the indirect costs of having to stay home until you receive one, if it's subsidized. The income tax exemption in Kenya was popular amongst the people that could access it, but it is limited to the formal sector. And in Kenya, most of the population, including people with disabilities, perhaps particularly people with disabilities, work in the informal sector. And the challenge with this as well is that it drops off after people reach a certain threshold equivalent to about $1,450 per year. So people that were receiving the program had to choose between keeping that benefit or progressing to a slightly higher income bracket. So that could be a difficult choice for some people. There were also other programs. So I mentioned briefly the quota, as well as some training programs. So these were rarely used because the application procedures were quite complex. And there was also poor awareness of these programs. And there was also poor implementation of the programs. So in both settings, the legal language around the quota was made it difficult to enforce the programs. And so enforcement was low, so compliance was low. And in both settings, I believe the quota was shared with other groups for women and I think orphans in one of the settings. So that is the end of my presentation, but happy to take any questions.
Okay, thanks a lot. Her presentation, I think, gets us a little bit deeper into how these extra costs play out in people's lives. There's one comment first from Sarah Ntenge from Kenya. She's from Kenya, who says that she's experienced discrimination in employment for a relative with a disability who was told to her face that we don't employ people on wheelchairs. But she congratulates the company in Kenya, the Safaricom, for employing people with disabilities. Yeah. The question, another question is, sometimes these extra costs are continuous and predictable, and sometimes they come in big clumps and maybe are unpredictable. To what extent did that issue arise in your interviews?
Yeah, I think that certainly both types came up. I think like if I look at healthcare costs, for example, I think the beginning part, they were very high and it was very unpredictable because people didn't kind of know what types of services, where they'd access them. So you'd see quite a lot of people sort of spending in a way that wasn't necessarily improving their functioning or their health in the long run. There's a lot of sort of, for example, searching for a cure for a disability. And so that was quite challenging. I'm trying to think of other sort of more unexpected costs. I mean, I think people certainly knew a lot of, if people had their disability for a while and had been accessing regular healthcare, they knew sort of what health expenses were coming. But you could have sort of a sudden breakdown of an assisted device that needed an urgent repair. And that's, yeah, challenging.
So if some of the people listening in here are thinking that they want to do a similar study to try to go out and figure out the cost of goods and services where they are, what advice would you give them for designing and implementing a similar study?
Yeah, so I mean, this one was more qualitative. I think if people wanted to then, so I think we looked at a lot of the dynamics of extra costs. So this was very much, in-depth interviews with people with different types of impairments. I'd certainly be interested to see how this is different in, say, a rural setting. I think if people then wanted to go on to quantifying some of the costs that we highlighted, I mean, there's different approaches. I think Stephen touched on some of them. There's the standard of living approach. You could do the goods and services required, or which would include unmet costs, or you could do the goods and services used, which would be more what people are actually spending on. But yeah, I think it's interesting. I think for future research, it would be really interesting to look at kind of how some of these costs vary in different settings, and also looking more at the role of policy in offsetting some of these costs. Because I think social protection is very important, especially cash transfers. I think there's been a big emphasis on cash transfers in recent years, and rightfully so. They're an important tool, but I think the complementary interventions are needed as well. So targeting, for example, issues of awareness and availability of the goods and services needed, and public investment in creating more inclusive environments.
Something that I've been wanting to do for years is to go into a country and use all these methods in the same country. And I think we're starting, actually I'm on a project with Morgan where we're starting to do that in some countries. And I know it's happening in a couple other places as well. And I think this, the combination of the standard of living approach that Stephen demonstrated and the goods and services required, they all have their strengths and limitations. I think we use them all together. I think it gives us a fuller picture of the lives of people with disabilities and the kinds of social protection policies that are needed and could be, will almost definitely have to be adapted to the context of the country with which you're working in. I don't see any other questions that posted. We have a couple more minutes, but maybe let me throw it back to Stephen and Morgan. Is there a last comment or maybe a question for each other that you might have?
I guess maybe one thing, I know it was quantitative data, but I was curious just with the way that health insurance works in the US, if there was a difference by cost on health insurance for people that have it or don't, because I'd imagine that's quite a big source for many people.
Yeah, so the data sets that we used don't actually get into whether or not a person has health insurance. So in the US, health insurance is predominantly private. We do have the Affordable Care Act, which extended health care to several million individuals who might not have otherwise been able to afford it. But outside of that, you're really limited to either healthcare that's provided that's means tested, so through Medicaid, what we call Medicaid in the US, or employer provided healthcare, which obviously requires having a job that provides that benefit, right? And so I think that there have been studies done on how much out-of-pocket expenses people with disabilities incur outside of their insurance. In fact, I think Dr. Mitra has a paper on this very topic, and she found that people with disabilities, even with insurance, after taking that into account, still incur much greater out-of-pocket expenses than people without disabilities. And so that's certainly, and then that's not even touching on the medical debt that people with disabilities incur, right? And so I think that's definitely an interesting component of it. So I don't know if that answered your question exactly, but yeah.
Yeah, no,
and thank you for your presentation. I think it's really interesting for me to see kind of the qualitative, to see this applied qualitatively, and to see what all can be done with the standard of living approach, the goods and services approach. And it really excites me about future research in this area, and really doing sort of mixed methods research, combining these approaches. And I think it's really important work. And I really think, Daniel, I thank you for your leadership in the area. And Morgan, thank you for presenting today.
And I think this is really a really important topic. A lot of countries around the world now are really have accepted this idea that there's extra costs of disability, but they're sort of in a place where they don't know how to move forward and actually incorporate it in an actual policy. So the kind of work that Morgan and Stephen and others are doing, I think, will be really valuable to them. And I thanks everybody. Thanks everybody for coming. I hope, I thought it was a great presentations and discussion, and I look forward to seeing what comes next. So thanks so much, everyone.
Thanks for moderating.
Bye.
Thank you.